Greetings and welcome everyone to today's webinar. Before we dive into our wonderful panelists who you can see on the screen and dive into our presentation today, we're going to take a moment to walk through the platform that we're utilizing. As you can see, IAMHP utilizes the GoToWebinar platform. As such, a GoToWebinar control panel should have popped up on the right-hand side of your computer screen. This is your window and portal into interacting with today's presentation. Hopefully all of you are able to hear me at this point. By clicking on your audio tab, you can move between your computer audio or your phone audio. Should you lose connection at any point with either your phone or your computer audio, you can switch. Please note that while you are switching, you will have a momentary delay. Do not fret, you will be reconnected. All of you should be able to see us right now via our webcams, but don't worry, you will not be on webcam today, and so you can disregard that tab. If you direct yourself to the questions tab, however, this is a very vital tab because it allows you to interact with me and all of our panelists today. We will be answering a few questions as we move along via the chat function. However, we will be pulling a few of those and asking those for our Q&A section at the end. Disregard polls and handouts as we will not be utilizing those tabs. And then the last and one of my favorite is our chat function. Unfortunately, due to some firewalls, you might not have the chat function. We apologize for that inconvenience. We've also noted that due to the version of GoToWebinar you have, you might also not have the chat function. But should you have it, you can interact actually with all of our attendees today, create community and space, talk about the presentation, or exchange and network via this platform. You can also connect with me. I'm coming up as IAMHP admin, as you can see, and you can direct questions or feedback to me as well. I will and maybe be utilizing this chat function to send updates to all of you. Without further ado, now that we have the logistics, we can actually get to the fun part and why we are all here today. And that is because IAMHP and CountyCare have partnered together to bring together this presentation on promoting health and reducing disparities in diabetes. My name is Elena Kennedy, and I am the Chief Operating Officer here at IAMHP. IAMHP stands for the Illinois Association of Medicaid Health Plans. As a member organization for the Medicaid Managed Care Health Plans, we work with Illinois state government, legislators, advocacy groups, trade associations to invest in and provide high-quality healthcare focused on cost-effective, individualized care that helps the residents of Illinois live longer and healthier lives. But as all of our panelists know and all of our attendees know, improving healthcare delivery systems is a never-ending job. That's why we work and partner with members and industry partners to achieve these better health outcomes. And as noted earlier, which is why we partnered with the Medicaid Managed Care organization CountyCare to present this informative presentation on addressing disparities in diabetes. Interestingly enough, before we actually dived in and got started today, Lucia and I was talking about how on my one of my first days at IAMHP, we actually met to discuss this important topic. And it's just so wonderful to see something follow through and come to fruition. And so really excited to have them walk through and discuss this presentation. So I'm going to step back and introduce Dr. Collins of CountyCare, Laurel of CountyCare, Webster of CountyCare, and Lucia of Illinois Public Health Institute so that they can take a moment and walk through this wonderful presentation with us all today. So Dr. Collins, welcome.
Good morning, Elena. I'd like to thank IAMHP for the invitation today. I'd like to thank my co-panelists for agreeing to participate today. And I would like to thank all of you for joining us today to talk about this very important topic as IAMHP and CountyCare present, promoting health and reducing disparities in diabetes. You may ask, why diabetes? Well, let me tell you why. Diabetes is the leading cause of end-stage kidney disease. Diabetes is the leading cause of new cases of blindness. Diabetes is the 7th leading cause of death. We know that 16 million emergency room department visits have a diagnosis of diabetes. 7.8 million hospitalizations have a diagnosis of diabetes, and we spend over $300 billion per year on the care for those who have diabetes. However, we know that it is preventable, and so that is our goal today, to begin to talk about how we move through the landscape of this disease. Our learning objectives today are to review how health plans develop programming to promote diabetes care to better meet the needs of members. Second, you will learn the importance of lifestyle change coaches to support members in the management of diabetes and the impact that it has on outcomes. And lastly, you will understand the National Diabetes Prevention Program and the Chicago Collaborative to advance reach, equity, and systems to prevent diabetes. Some of these numbers we may know, but let's level set a bit this morning before we start. There are 34.2 million people living with diabetes. That is 10.5% of the US population. Surprisingly, of those, 7.3 million people, or 21%, are undiagnosed. Prediabetes, which is key because we know that if we prevent prediabetes or control it, we won't have those cases of diabetes. There are 88 million people aged 18 and over who have prediabetes, almost 35% of our US population. And the Medicare population that is 65 and older continues to grow, with 24.2 million people affected with prediabetes. You will see this graphic later, but I wanted to go to the bottom of this graphic, which is the most important part of today. If you look on the left side at the very bottom, the government can't do it alone. Faith-based organizations can't do it alone. CountyCare can't do it alone. Hospitals can't do it alone. In order for us to prevent diabetes, it's a concerted effort for all of us to participate in how we make an impact. If you look at the right side of this graphic, we know that if we intervene, that is with lifestyle interventions, which we'll talk about a little later, we can cut the risk of type 2 diabetes by half. So taking that 33 million to 15 million is drastic in terms of cost. When we look at the trends of diabetes over the last 20 years, we can see that the total number of cases continues to grow year over year. When we look at the prevalence of diabetes, if we focus on the top graphic, for every decade of life until you get to 75, diabetes continues to grow, and the number of cases in men surpasses that of women until you get to 75. But nevertheless, if you continue to look at those last three bars, that's our population in terms of Medicare. So this disease is not only important for Medicaid populations, but also for Medicare populations. If we look at the bottom graphic, which again, I think is astounding, if you look at 2004, and let's focus just on the intensity of color, the dark blue being the percentage of our population with diabetes. You can see from 2004 to 2016, the drastic numbers of our populations that are now inflicted with diabetes. Again, a role for all of us to work toward prevention. Another key factor related to diabetes is if we look at the white non-Hispanic population, those that have diabetes is 7.5%. However, if you look at every other race and ethnic group, they are all 1.5 to 2 times more likely to have diabetes. If we focus here today, the highest risk being in American Indians and Alaskan Natives at 14.7%, the Hispanic community at 12.5%, and Black non-Hispanics at 11.7%, but all higher than that 7.5% we see in the white non-Hispanic population. So a lot of room there to talk about why are there differences in race and ethnicity and what we can do about it in terms of prevention. Lastly, we know that there are mechanisms in place to prevent those diabetes-related complications. So at least one source of diabetic care That is, a member seeing either their primary care provider or endocrinologist decreases that risk by 34.2%. At least 150 minutes of exercise per week, that is a simple 21 minutes per day, decreases your risk of diabetic complications by 15.8%. Managing or losing weight, and Lucy will focus a little bit more on this, but just as small as 4% of your current weight improves your risk related to diabetic complications. And for those members that are 40 to 75 who have hypercholesterolemia, simply the addition of a statin can decrease your risk of diabetic complications by 13.2%. So as I started this talk in terms of prevention, we know that the measures listed here will decrease the numbers of patients we have with amputations, will decrease the risk of a number of patients we see with end-stage renal disease, will decrease the number of patients we see with blindness. And so I ask you this morning as we go through this talk, how can we not talk about how we move toward prevention and how we fund that? I will now turn it over to Laurel Chatty, who will provide the health plan perspective of initiatives around diabetes care. Thank you, Laurel. Laurel, if you're speaking, you may be on mute.
Yeah. Thank you, Dr. Collins. My name is Laurel Chatty, and I'm the Manager of Population Health and Performance Improvement with CountyCare. And as Dr. Collins mentioned, today I'll be talking about some of the health plan initiatives we've taken to address diabetes. So before programs can be implemented, it's important for CountyCare to understand the membership we serve. As of February 2021, CountyCare had an adult population of approximately 200,000 members. Approximately 12%, or almost 25,000 members, have a diagnosis of diabetes, greater disease prevalence than that of the US population. Similar to some of the statistics Dr. Collins presented, diabetes is the top diagnosis among CountyCare's adult membership. Diabetes is also one of the top diagnoses for inpatient admissions, contributes greatly to medication or pharmacy spend, and overall medical spend in general. In short, diabetes impacts a large portion of the CountyCare membership, and it costs us a lot of money, making it a chronic condition we've invested additional resources in. On the next slide, this is where we'll discuss data capture, as data capture is key to supporting CountyCare's diabetes care work. Providers and care coordinators need accurate, timely, and actionable data. CountyCare has worked to incorporate additional data sources into our HEDIS measure performance to paint a more complete picture of the diabetes care services members need. This includes gathering HbA1c results from a results feed with several lab vendors and incorporating electronic medical record data to monitor blood pressures, for example. On the next slide, CountyCare then holds quarterly performance meetings with providers and care management. If you want to go to the next slide, please, Dr. Collins. During these meetings, we are able to share reports, discuss quality initiatives, and ways to further collaborate to best support CountyCare members. The first report shared is a HEDIS measure performance report to show providers how they perform on priority HEDIS measures compared to CountyCare overall. The HEDIS measure performance report includes a scorecard with the provider's current HEDIS rates and target goals, in addition to a member list for each measure that highlights members with gaps in care. The member list includes contact information to then outreach members and help them schedule appointments. The second report shared is a membership and utilization performance report. This report allows a deep dive into the provider's membership with the ability to filter on different factors like age, gender, and risk level. It also includes a chronic condition summary helping providers to understand the most prevalent conditions within their CountyCare membership and how it may vary when filtering by different factors. On the next slide, once we have assessed our target population, we can begin to roll out programs to support members. One program we have supporting members with diabetes is the Member Self-Management Program with Canary Telehealth. This program features a mobile phone-enabled app members use to log biometric data and learn about ways to manage their chronic condition. The goals of the program are to improve member health outcomes by empowering members with tools to help manage their diabetes and engage with their health care. The program was initiated in February of 2020, and over the past year or so, 1,600 members have enrolled. On the next slide, I'll go through how the program works. So Canary Telehealth will outreach a list of members CountyCare has identified with diabetes and meeting the program criteria. If a member is agreeable to program enrollment, Canary Telehealth will help the member obtain glucose testing supplies and train the member on how to use the testing strips and glucometer. The app will prompt the member to record their blood glucose reading on a daily basis and provide the member with a log of their glucose readings over time so the member can monitor trends. On the next slide, the other component of the program is focused on education. Members are asked questions about any symptoms related to their diabetes, medication adherence, lifestyle factors like eating and physical activity habits, and social determinants of health to help members if they need assistance with food or transportation to appointments. Based on how a member responds or answers the question, the app provides feedback or an action to take. On the next slide, we assessed member experience with the self-management program. We conducted a satisfaction survey in May of 2020 and surveyed a sample of 28 members who had been enrolled in the program for at least 3 months. Members reported positive outcomes related to tracking their glucose readings and receiving the health education. But most importantly, what we saw is 79% of members reported a behavior change in their health habits. To assess improvements on the next slide, with members receiving their recommended diabetes care and screenings, we compared HEDIS measure performance between members enrolled in the self-management program and CountyCare overall. What we see is members enrolled in the program were more likely to have had a visit with their primary care provider, a hemoglobin A1C screen, and diabetic retinal exam in 2020. As the member self-management program continues, CountyCare will continue to monitor outcomes to assess the impact. On the next slide, to address one of the things that we have learned that can be an issue for many CountyCare members, which is transportation. We've added a program that offers in-home appointments for diabetic retinal exams, and we recently expanded this in-home service to include diabetic labs. Over 4,400 diabetic retinal exams have been completed since the program began 2 years ago in February 2019. We are currently using data to take a targeted approach by first outreaching members who did not complete their diabetes care screenings in 2020. CountyCare also offers a member rewards program on the next slide to incentivize members to complete their diabetes screenings, in addition to other preventative care services. Weight Watchers vouchers are an additional benefit offered to members to help with lifestyle factors related to diabetes management. On the next slide, to recap, CountyCare starts with data to inform providers about their membership and members in need of diabetes care. CountyCare then offers targeted programs to further support the needs of members with diabetes and engage them in their health care to bring about behavior change. Now I will pass it to Webster Vital to discuss health system approaches to diabetes care.
Give me one moment, Webster. Let's just make sure your audio is working. There you go. You should be able to speak now.
Thanks, Laura. My name is Webster Vitale. I'm one of the managers of Cook County Care Coordination team and overseeing the community health workers. And today we're going to talk about the system initiatives. As system initiatives in Cook County, the Care Coordination Diabetes Program focuses on reducing disparities in diabetes care and enhancing outcomes through clinical and community interventions. The implementation of multi-level, multi-component intervention helps to enhance patient skills, clinician cultural competencies, and healthcare system changes to address disparities and enhance care. Across our clinics and communities, the multi-component approach focuses on three components: the patient component, the clinician component, and the system change component. In the patient component on the next slide, education and support are provided to patients to help them learn how to take the best care of themselves. The patient component is important because people who have knowledge and support to manage their diabetes are healthier than those who do not. Empowering and equipping patients with the necessary skills to manage their diabetes help avoid or delay serious health complications. The skills patients learn in this component includes the ABCs of diabetes, understanding their A1C levels, the importance of blood pressure and risk associated with elevated pressure, cholesterol levels and how it increases risk of heart attacks, strokes, and other serious problems. Eating healthier food in the right amount at the right time to help keep blood sugar in target range. Tips surrounding meal prepping, including how to include more non-starchy vegetables and fewer sugars and refined grains, assistance with grocery shopping, understanding how to read food labels, the nutritional labels, for instance, eating more foods that are higher in vitamin, mineral, and fiber. Getting active, physical activity is important. Really coaching patients to get at least 150 minutes per week, 20 to 25 per day. Glucose monitoring, the typical times for patients to check their blood sugar when they first wake up, before a meal, 2 hours after a meal, at bedtime. More importantly, setting a diabetes care schedule and goal setting with patients are important. We really go over the everyday process, everyday schedule, blood sugar check, food check, diabetes medication taken, physical activities, healthy eating. And if patients are not within their goals, we recommend that every 3-month check with the PCP or a A1C level testing. But if they are within their goal and meeting their set goals, then we do recommend that every 6-month dental exam, A1C level meeting with the PCP. And obviously every year we encourage flu shot, kidney test, cholesterol test, dilated eye exam, and complete foot check. For the clinician component on the next slide, clinicians play a very important role in helping patients manage their diabetes. So enhancing patient and provider communication skills by using culturally competent or culturally appropriate language, shared decision-making, and goal-setting techniques are key factors in the clinician component. Providing clinicians with training to enhance sensitivity and cultural competency help in tailoring program materials and treatment options specific to patients. This is particularly important as we work to end health disparities in high-risk and vulnerable populations. We understand that some groups of people are affected by prediabetes and diabetes more than other groups due to differences in health status or access to health care among racial, ethnic, geographic, and socioeconomic groups. In our system change component, we understand the optimum treatment of diabetes can be complicated and time-consuming for patients and their physicians. During a 15-minute office visit, it is often difficult for primary care providers to provide quality acute, chronic, and preventative care while building meaningful relationships with their patients. During these visits, primary care providers also deal with managing multiple diseases. One solution to expanding time, improving quality, and strengthening the patient's ability to manage his or her diabetes is by utilizing a care team model. The care team model consists of a registered nurse, social worker, LCPC, community health worker working together to provide coordinated care to patients with diabetes. The registered nurses and the community health workers really work hand in hand to set and document goals collaboratively with patients while integrating evidence-based guidelines and delivery of care. As they educate patients on their care plans and coaching them through lifestyle changes, linkages to community resources and organizations like DPP are helpful in supporting patients in their treatment plan. As a care team, we provide continuous support and effective care for patients with diabetes throughout the course of their treatment, really assisting them in the prevention of complication and management of chronic disease while providing health promotion and disease prevention. The care team is a key component of system change and efforts to really reform healthcare and quality improvement initiatives that incorporate an integrated healthcare delivery system, especially for those for chronic disease and prevention management. With these efforts, we anticipate on a larger scale policy change, advancement in Medicaid and payer coverage while building system and infrastructure to really support the long-term programming and sustainability within that level. In our outcomes, what we've been able to identify are we're able to see enhanced patient and provider communication skill increased, right? More resources are provided and support given at the clinics and communities to increase exercise and healthy eating options. We've also been able to help with blood pressure, but keeping blood pressure below 140 over 90 or lower in other cases. We've also been able to assist patients with their LDL cholesterol below 100, A1C levels below 7%, and just really increasing patient education throughout, throughout using low cost and pre-existing educational materials like the ADA. And one in particular we're able to really focus in on is the food insecurity pilot project, which we were able to implement on a system level throughout the vulnerable populations of Cook County. And in that process, we take the time to really educate folks and assess their health before enrolling them in this program. And in this program, we're really providing members with fresh produce, 7 days a week meal program for folks who identify as food insecure and have trouble managing their diabetes. And the outcomes is really how we really can make a difference in their A1C level and how they manage those, and really just coaching them while providing them the resources through our partners with Chicago Greater Food Depository to really provide meals to support and really identify what areas we can help as patients empower themselves and take control of their diabetes management. And as a result of this pilot program, we were able to see 96% of participants change eating habits, 98% increased exercise activities, and 97% really had a change in lifestyle behaviors as a result of the program education piece. So we really believe through linkages in our communities, we can really make a difference with diabetes programs. And now I introduce Lucia Flores with DPP, our partner initiatives.
Great, thank you so much, Webster. And my energy is fortified and renewed just by listening to my colleagues present on the work happening at CountyCare and CCH, who we do partner with in this initiative. So thank you again, Webster. Hello, everyone. My name is Lucy Flores, and I oversee the Chicago Cares project at the Illinois Public Health Institute. I'd like to thank CountyCare and IAMHP for hosting me in this space to share information regarding the Chicago Cares project and highlight the importance of the CDC's recognized lifestyle change program known as the National Diabetes Prevention Program, and I'll refer to it as the DPP going forward. Next slide. The goal of the Chicago Cares project is to reduce diabetes disparities among Black and Latinx communities by expanding the number of diabetes prevention program providers in Chicago, thereby increasing the number of individuals participating in the CDC-recognized lifestyle change program. Through funding from the CDC, the Chicago Cares project works with partners across sectors to create access to the DPP and provide resources and technical expertise to support sustainable DPP models in Chicago. The Chicago Cares project is part of the Illinois Public Health Institute, and we are an organization dedicated to leading action to improve public health systems, health equity, and quality of life for people living in Illinois. The Illinois Public Health Institute is the fiscal agent for the CDPH, and we administer all aspects of the project in collaboration with the Chicago Department of Public Health. Next slide, please. So a little bit about the national landscape. In 2010, Congress authorized the national DPP because previous research demonstrated the potential of the CDC-recognized lifestyle change program to prevent or delay the onset of type 2 diabetes. The DPP was a major multi-center clinical research study that played a seminal role in the prevention efforts we're discussing today. The Chicago Cares project is part of this larger national effort to prevent diabetes, and our work, like the work of partners in other states, relies on cross-sector collaboration. The scope of our project covers a wide spectrum of activities from policy to direct practice and implementation partnerships. On the policy end, we are working on the sustainability of the DPP, which includes payment options for the DPP, such as Medicare and Medicaid coverage. Dr. Collins mentioned this earlier, and in 2018, the DPP became a Medicare-covered benefit. And 3 of our Chicago Cares project partners who are DPP providers are currently working on becoming Medicare DPP providers, which would allow them to submit claims for reimbursement of services. States like New York, Pennsylvania, and Maryland have worked toward and achieved Medicaid coverage of the DPP. And through the National Association of Chronic Disease Directors, Illinois is also part of a learning collaborative exploring Medicaid coverage. And some of the NCOs on this call actually may remember conversations with IPHI and HFS and IDPH on this topic. Our work also encompasses direct implementation activities with the goal of expanding the number of organizations offering the DPP. Through our project activities and subject matter experts, we train the workforce that delivers the DPP, thus ensuring quality and adherence to proven standards. And as the graphic in my previous slide indicates, one of our strengths is working in that partnership zone with community and clinical linkages. In collaboration with the AMA, we work with organizations to develop workflows, population health approaches, point of care strategies, and referral pathways to identify and refer eligible individuals to the DPP. As you'll see in the next slide, the Chicago Cares Network works with FQHCs, CBOs, health and hospital systems, the IDPH, the Cook County Department of Public Health, and the Chicago Department of Public Health, all with the goal of addressing the growing threat of 86 million adults having prediabetes and 15 to 30% of folks in that group developing diabetes in the next 5 years, which I'm sure there are people on this call who can do some quick math and come up with some grim stats, including the negative impact on individual lives and the associated healthcare costs. Here I'll discuss the Chicago Cares project and the work we do to give our patients, our members, and Chicago communities a chance. This slide represents an overview of the work we are doing in Chicago specifically. Through the CDC's funding, our work emphasizes and focuses on preventing diabetes in Chicago. Although the focus of my presentation is the diabetes prevention program, I'd like to provide a bit of context and where the DPP implementation sits in the larger Chicago Cares project. The CDC opportunity funding opportunity, categorized focus areas as numbered strategies, and that's how this project overview and activities are represented in this diagram. You'll see the numbered strategy and the partners funded through this project to advance our work. We've worked with the Alliance Chicago to explore bidirectional e-referral systems to establish communication between DPP providers and referring partners, such as healthcare providers, CBOs, and other referring entities. One of our main challenges is interoperability between EHRs and external communication platforms, and I'm sure that's no surprise to this group. We are currently working with the Alliance Chicago FQHC member, Erie Family Health Center, and a NowPow pilot project to track referrals to the SUHI, or Sinai Urban Health Institute, Diabetes Prevention Program. Our work in DPP expansion includes funding 11 organizations to deliver the DPP throughout Chicago, focusing on the south and west side of the city where there is higher incidence of diabetes and further complicating factors like COVID-19. I'll come back to this work and provide greater details in the next slides. As I mentioned earlier, we also train lifestyle coaches, which is our strategy A4, to deliver the year-long program. And I provide advanced technical training such as cultural humility, motivational interviewing techniques to support long-term behavior change for participants. CDC evidence indicates that coach characteristics impacts DPP group outcomes, and we work with the ADCES to convene bi-monthly learning collaborative sessions to improve and enhance the coach skill set and qualities. In tailored communications, we work with a communications contractor skilled in developing marketing and communications media, tailored to increase awareness of pre-diabetes and the DPP in communities of color. The Chicago Cares team at IPHI includes multilingual, multicultural people of color and lifelong residents of the communities this project aims to serve. And our team has provided direct consultation and informed direction and strategy to marketing and promotion activities. Similar to what CCH is doing with their patients, we've continuously worked with partners to identify, develop, and test innovative ways to eliminate barriers to participation for folks in the DPP. This includes access to resources such as behavioral health, access to food, financial literacy, employment and economic opportunities, in addition to focusing on COVID emergency response, testing, and vaccination efforts. Lastly, we're also working on expanding the number of organizations providing diabetic retinopathy services, thereby increasing the number of individuals who are screened via telehealth. This is the only area in scope of work that covers work with individuals already diagnosed with diabetes. Again, all this with the goal of improving systems and improving health outcomes throughout communities in Chicago facing greatest risk and greatest disinvestment. Next slide, please. So what is the DPP? Many of you may already know, but it's a year-long program delivered in a small group setting to a class of 15 or less participants by a trained coach and on a CDC-approved curriculum focused on supporting healthier eating habits, increasing physical activity, and stress management techniques with the goal of achieving 4 to 7% weight loss. It's been proven that individuals achieving this weight loss can successfully prevent or delay a diabetes diagnosis, that in turn results in substantial long-term savings and healthcare costs. I'd like to add that a year-long program can seem like a long time. However, the total number of hours invested are approximately 24, and it's important to acknowledge that food culture is developed over a lifetime of experiences, and the year-long support gives individuals the benefit of time and time to learn, apply, and build new knowledge, and even fail before adopting new behaviors and learning strategies to become successful at lifestyle change. I think many people in this group are familiar with the stages of change, and behavior change such as this is non-linear, and many of us are in a continuous cycle of self-improvement and practicing healthier lifestyle practices. Next slide. So the Chicago Cares Project works with 11 organizations, including, thanks, Dr. Collins, including FQHCs, CBOs, and health and hospital systems on DPP implementation. In this table, as you can see, the number of years is represented and the number of classes each organization has been funded to launch. This project to date is on year 3. And here you'll see the enrollment number equals class size, which typically is 15 participants. So if an organization is funded to launch 4 classes, that means their capacity equals 60 participants. The total number of classes launched in Chicago over the past 3 years are 47 classes among 9 partners, with a total number of classes in Chicago being, as I mentioned, 47. The number of classes planned for this coming year, which would be year 4, are 25. Classes are primarily focused on the south and west side of Chicago, working again with Black and Latinx participants. Classes are offered virtually during the daytime and evening hours across platforms like Zoom, WebEx, and Google Classroom. The age range across all participants for the group includes 27 through 72, and most participants meet eligibility criteria via documented A1C levels versus the risk test, which is an acceptable way of being enrolled in the program, but many of our members are meeting the clinical documentation criteria. Participants receive materials such as stretch bands, measuring cups, weight scales that are non-digital, food and physical activity journals to document activities in order to support and reiterate curriculum content. There's a lot of infrastructure required. There's eligibility algorithms, clinical workflows, provider engagement, internal promotion, and CDC reporting requirements that come with this project. My colleagues at CCH can vouch for all of these requirements. And they're definitely challenges, but I think that they're also things that can be integrated into already existing systems and infrastructure within many of our healthcare partners. Next slide, please. So this is a map of organizations in the Chicago Cares Network providing DPP services. Not represented here are the Alivio and Mercy Loyola DPP programs because we don't fund them, but they do receive technical assistance and support from the Chicago Cares Network. And we will be adding 2 newly funded partners, Iman, which is the inner city Muslim Action Network serving the South Side, and the Chicago Lighthouse to this map. We are continuously looking for referral or DPP partners, so if anyone here has any great ideas for collaboration, I'd be happy to talk. Thank you for starting your morning with us, and I'll turn it over to Dr. Collins.
I'd like to thank the panelists. Thank you, Laurel. Thank you, Webster. Thank you, Lucy. I think you all can see based on what we've presented today that prevention really does work. I just want to take a moment to focus on the slide that you all may not have been attuned to, simply stating that if you decrease your weight by 5 to 7%, you decrease your incidence of diabetes by 58%. For those over 60, learning lifestyle changes decrease the incidence of diabetes by 71%. So this is important in terms of prevention. Number 1, identifying those that are pre-diabetic and then intervening so that we don't get to the stages of diabetes. You then saw from the system level and from the health plan levels, really the importance of 2 aspects when we look at diabetes care. That is the member aspect, so identification of the member who has diabetes, interventions where needed, identification of barriers and how you get past those barriers, and really that member education, member engagement, which I think you saw throughout the presentation, then leads to member satisfaction and really wanting to improve their health once they know what to do. We also learned the importance of the provider side. That is, providers have to know where those gaps are. And so we as the health plan can help them identify which members have not had their various diabetic screening tests so that they can focus on those members. And then once they know though they have diabetes, they can begin again to have conversations around what it means to have diabetes and what you can do differently in terms of those lifestyle changes. So as we conclude this morning, we have seen that the percentage of individuals with diabetes continues to increase. We need to look at how we can decrease that trajectory for this disease. On average, managing diabetes costs the health plan $9,600 per year per patient, 2 to 3 times higher than what we pay for members that don't have diabetes. We learned that pre-diabetes is identifiable. So if we can identify it, we can intervene. We also know that those prevention measures, so those lifestyle changes that we talked about, what you eat, how you shop, and what you buy when you shop, exercising, controlling your blood pressure, controlling your cholesterol, controlling your weight, all of those prevention measures are known to help. But more importantly here is, I would like everybody to get the thought process in place. Prevention programs are beneficial. And really, how do we move the legislation and the advocacy that we begin to focus more on prevention of disease, and that diabetes, of course, but really any disease, and then how we move away from treatment. So again, thank you very much for spending time with us. Thank you again to the panelists. Thank you to IAMHP, and we will be happy to answer any questions.
Well, first of all, I just want to pause and say thank you so much to our wonderful panelists for sitting down with us today, albeit virtually, and walking through all that they do. I just need to say that their passion and dedication was palpable, and my hand is hurting from furiously writing down notes for the presentation. So don't worry if your hand is also hurting and you can't keep up with all the notes. We will be sending around a recording of today's presentation to everyone. So you can also review it again. Lucia, you made a wonderful point that just has been resonating with me after it, talking about how as we evolve and are on this continual education, you know, where our habits will ebb and flow as we go about life. And so having that 1 year to really develop some life skills and train ourselves to address diabetes is really important, and just having the grace for us as our individuals, but also patients and members as they evolve and try to grow and have healthier lifestyles is just so important. So I just wanted to say thank you so much for that comment. Just before we dive into our question and answer section, I just want to remind everyone that you can submit your questions and via the questions tab or the chat tab. So feel free to submit those to me. All right, perfect. So I'm going to kick it off though with my first question. So this is open to everyone on the panel. We know that adherence with diabetic retinopathy, oh my goodness, that is a bit of a tongue twister to say. Diabetic retinopathy screenings are difficult quality measures for health plans and providers. And, you know, a lack of screening is more profound in populations where there are access challenges and other barriers. I saw that the data that people on the self-management program you have with Canary Telehealth are more likely to see their provider. How do you think the Canary Telehealth program and app helps with that?
Laurel, do you want to take that one?
Sure, I'd be happy to. I think because it's asking members the questions, and members are then curious to either get the answer or to further seek out care. It provides feedback to the members to either direct them, or if they do have a condition, you should really be reaching out to your healthcare provider or reaching out to your care coordinator. I think it's just a great bridge between the provider, the care coordinator, and the member, and to really just empower the member then to seek out the care and be proactive about getting the care that they need for their diabetes management.
Yeah, Elena, I'd like to echo that. I think we know with this population, sometimes there are some literacy challenges, and sometimes it's just a matter of they don't know what they need related to their disease. I think the self-management program is an excellent opportunity to begin to engage the member and then educate the member, and then they really know based on the questions that are asked what they need. And then that allows them really, in a lot of scenarios, to begin to have that educated conversation with their providers on what they need, including that diabetic eye screening.
I have to say that on the Chicago Cares end, as we work through supporting expansion of diabetic retinopathy screenings, I agree. I think that it's so important to communicate with individuals like the next step to take and action, right? What is the action to take, whether that's connecting with your provider, whether that's connecting with a screening service or a screening program with a care coordinator. I think that the healthcare system in the US is overwhelming, and we often receive competing or conflicting messages from our healthcare system and providers. And so I think that connecting individuals via many ways, whether it's a warm handoff, whether it's an online platform, that we communicate the next actionable thing for an individual to take, so that they can own their healthcare and manage their healthcare activities.
Yes, I couldn't agree more. And I'm going to direct my next question actually then to Webster, because I loved how you walked us through that care management perspective. And we know that some of these individuals haven't been tapped into the healthcare system, or have been utilizing, emergency rooms to manage their diabetes or other chronic illnesses. And so from the care coordination perspective, what are some lessons learned, and how can we as an industry continue to support our members through care coordination?
Yeah, great question. And right off the top, you sort of hit it. We just have those populations where they don't have that coordinated care effort, that team to really just help them manage or even understand how to navigate the health system. Nevertheless, their health plans, and really understanding the benefits that are provided. So I think the care coordination unit really, as we grow and learn, we know that these patients, that education is a big piece. Really just equipping them with the knowledge and the resources of us really working as a interdisciplinary team, working with these members to not just provide support for managing their diabetes, but understanding the social determinants of health, identifying the risk and barriers, as Dr. Collins mentioned, that prevents them from how they act, how they best manage their care, and how they access care, and ensuring that they are on that the diabetes schedule annually, daily, and weekly, and understanding that. So really just getting into the communities and setting those goals, we've been able to really just improve our HEDIS measures surrounding some of these processes and these approach, and just how we work with the members interdisciplinary. Mm-hmm.
One of the things that I think Chicago and Illinois does very well is actually having community. We're a very community-based city and state, and it's so interesting to me that we would silo our healthcare systems, because that's not how we connect. We connect in community. And so I think the work of care coordinators is so vital to bridge those gaps and really kind of act as that healthcare community element. To that component, I'm also going to direct my next question to Lucia, but I think Dr. Collins, feel free to pepper in. As you were talking about the programs, the year-long programs, you said there were 16 small groups. How was that number decided? And then I also noticed on the chart there were a few different health systems that you had partnered with. How were those health systems decided as well?
Mm-hmm. Yeah, thanks for asking. So the way that the funded partners have been identified is through a request for applications. Organizations submit applications to be funded and to implement the diabetes prevention program with their internally within their own organizations, serving their internal clients or patients. So that's how we selected the number of partners that you currently see either on our map or on our list. All of the project partners are on the Chicago Cares dpp.org website, and how to access classes. All that information is online. And the individual number of classes are determined by our project partners. So for Erie Family Health, if they have capacity and the infrastructure to launch 2 or 4 classes in a year. That really is determined by the organization and the internal capacity and infrastructure needed to facilitate a class, to pull EMR queries, to identify provider champions on this project. So it's really determined by an RFA, and then the number of classes are subsequently determined by the organizations themselves and the capacity they have.
Dr. Collins and all of our panelists, we have a variety of different attendees from all walks of life, but all ultimately working around healthcare, diabetes work. What would you say is the most important thing that you would like all of our attendees to walk away with today or ruminate as they think about investing and continuing to build a healthy, thriving healthcare system for our members?
I can start. I think number one, it all starts with access, because I think if members are not seeing their primary care doctors, they're not going to get those labs that are going to help us identify that pre-diabetic state. So access for one, making sure our members, our patients, our friends, our families are seeing their primary care providers. Second, with that, when abnormalities are identified, especially as we talk about diabetes, so hemoglobin A1C, to intervene. Because if we can begin to educate in the pre-stages of any disease, we know that makes a significant impact on stopping the increased incidence of that particular disease. And again, diabetes is a key example. If we begin to identify those members with an abnormal hemoglobin A1C, begin to educate them on what they can do for prevention, we know it makes a difference. So I would say access, identification, and then prevention.
I read recently that in Illinois specifically, about 3.3 million adults have prediabetes, and 85% of Americans who are pre-diabetic don't even know it. And so I think a great point is screenings, opening up a dialogue, whether you're a provider, a health plan, or within the space with your friends, your families, to open up those lines of communication and do those screenings. It's really important as well. Great. I actually am receiving a lot of compliments to the presentation. Thank you to our panelists. I just want to extend all of the positive feedback I'm receiving. If people are interested in connecting with you or partnering with you in some way, can they reach out? Is there a way for them to also connect with you after today's presentation?
Absolutely. What I will do is I will send all of our email addresses over. But again, yvonne.collins@cookcountyhhs.org. But I can make sure that you have all of our contact information. We definitely are open to having conversations with partners and building relationships. We know it takes a concerted effort for us to work together on healthcare.
That it does, but I will say all of our panelists today are taking those important next steps to really address those who are living with diabetes or pre-diabetic. And so I just want to say once again, thank you so much for all you're doing. It was just a fantastic presentation as well, and I can look forward to continuing to see what you do after today's presentation, and look forward to continuing our partnership as well. With that, thank you to all of our attendees for attending today and taking an important hour out of your day to learn about this, hold community, and ultimately investing in the members that we serve. We really, truly appreciate it. Once again, we will be circulating around the slide deck and recording to all of you as well. We will be posting this onto our website, and I actually encourage you to check out our website, IAMHP.net, as well as our LinkedIn, Facebook, and Twitter to learn more about what we're doing at IAMHP, see what the other health plans are doing as well, and view other videos that are helpful, such as this. We have a variety of other webinars about what other health plans are doing surrounding maternal health, infant health, children's mental health, community engagement, other videos about diabetes, vaccine hesitancy as well. And so just some fantastic educational tools and training materials on our website. Also, if you're interested in becoming a trusted partner, I encourage you to reach out to myself or visit our website to learn more of how you can partner with us directly. But as always, all of our panelists are available to connect and partner with them as well. With that, we are going to be ending today's webinar and look forward to talking with you all soon. Have a good one and goodbye.
Thank you, Elena.
Thank you.